I now call upon Dr. Karobi Lahiri. She's a very senior vitreoretinal specialist from Mumbai, like Dr. Vatsal Parekh, also very senior retinal specialist from Mumbai. So Dr. Karobi will talk to us about red and yellow spots seen on fundus examination. So what are we looking at?
Thank you, Paritosh, for the topic, and good evening, everyone. I'm going to speak to you about red or yellow spots seen on the fundus examination. What's that? Now, when I was given this topic, I started thinking, and I thought that everything in the retina that you get, pre-retinal, intraretinal, subretinal, everything is yellow or red. Maximally it can be black somewhere, it can be brown somewhere, it can be white, but majority is white, yellow and red. So I didn't know how to this, but I hope I can do some justice to it. So this is how it would appear, whether we are talking about hemorrhages, we are talking about abnormal growths, we are talking about aneurysms, which can be macro or micro, or it could be cotton wool spots or hard exudates. Now the important thing is that if we label it together, red spots, hemorrhage, macroaneurysms, new vessels, macular hole, cherry red spot. If you talk about yellow spots, it's hard exudates, soft exudates, drusen, RP atrophy, scars, CNVM, CRA patches, flex, egg yolk appearance. And if you talk about both, there are conditions in which you get both, which you have to label, which is could be a diabetes, hypertension, age-related macular degeneration, PCV, CMV retinitis, or a CRVO. So the thing is that important thing is that when you get red or yellow spots, and especially this is for the postgraduates who are just learning to start seeing these lesions, you have to identify it by a systematic manner. That is, you take a very careful history. So the history gives you half the diagnosis, whatever it is. Especially recurring conditions like diabetes, hypertension, these are common things. So you have the first differential of this in your mind. Go to the depth, whether it is superficial or deep. If it is exudates, see whether it's a soft exudate, which is superficial in the nerve fiber layer, or if it is in a deeper level where it could be hard exudates in the outer plexiform layer. If you have a color and configuration, you have very shiny yellow discrete hard exudates. If you have something pale yellow irregular margins, variable shape, superficial, soft exudates. If you have a drusen, light yellow, round, fluffy, or discrete, you know this could be a drusen at a little deeper level. Then come to hemorrhages. It could be flame shaped, superficial, flame like, red, dot and blot, little more round or a little fuzzy, and a little deeper layer, rod spots, where you can have a flame shape with a center which is particularly particular to certain diseases like endocarditis, or even in other conditions like anemia and all, you can get it. And deep, you have to see whether it is deep in the pre-retinal. That is different. They have all spoken about pre-retinal. I'm not going to touch that. Subretinal, sub-RP, or it is in the choroidal layer. Now, on the right, you see these flame-shaped hemorrhages, which are superficial. You have the dot and blot over here, which is a little deeper, and this is the shiny hard exudates, which is again in a slightly deeper layer. So one has to get to know, do an indirect ophthalmoscopy, because that gives you a 3D picture, and you know what level the lesion is at. So you are better to mesh it. Now, retinal vascular diseases is what comes to your mind when you think of exudates, hemorrhages, hard, soft, and all the other things. So a typical hard exudate, shiny, circinate rings, or it could be pale yellow, which is cotton wool spots, again dot and blot hemorrhages, microaneurysm, small round pinpoint near the capillaries, small lesions, and otherwise combined occlusions, or you have superficial hemorrhages, which is accompaniment of any RVOs, and then you have vascular loops, beadings. These are all things which are red lesions on the eye, typical of vascular disease. Mactel, where you get a small round with a halo around it, or you have coats where there's a lot of exudation involving the center, and these exudations need not only be in the center, it can be in the periphery also. So multiple causes, I mean the list of causes is endless. Diabetic retinal vascular disease, ocular ischemic syndrome, sickle cell retinopathy, hypertensive retinopathy. I'm getting tired of telling you all this. And the bacterial endocarditis, where you get the typical rot spots, and then come to the lesser causes. Then you come to the age-related degenerations, the juxtafoveal telangiectasia or the PCV, which have a different format altogether. And in children, do not forget, if you see hemorrhage in a child where there is no history of any other problem, it's a shaken baby syndrome. Now, embolizations can be from embolization of amniotic fluid, which can give rise to exudates. It could be infective, it could be toxic because of interferon or methotrexate, it could be radiation induced, it could be immune mediated because SLE, sarcoidosis, dermatomyositis. There's a host of conditions which can give you soft exudates. And when it comes to blood diseases like aplastic anemia, dysproteinemia, pernicious anemia, these are also known to give various kind of similar kind of lesions. So basically, if you have to know what belongs to what, it is like if you have 3 Karobis in a room and you want to know Karobi Lahiri, you have to fit her characteristics to that. That is, she's fat, she's fair, she limps, all these things you have to put, okay, this is Karobi. So similarly, when you want to stratify a condition, you see the accompaniments along with it and the natural history, what you get on your examination, what you order in a meshed form in your investigations, and that is when you decide, okay, I'm dealing with this. This is the form of treatment which I would offer, which would work best for the patients. And then there are non-steroidal anti-inflammatories which can give rise to bleeds in the eye. There are several other medications. So the history is of prime importance because you have to take all these histories. The interferons which are given for viral infections also can be linked to eye bleeding. So now let's go over and just see the photographs of these people. This is a branch retinal vein occlusion, lot of superficial hemorrhages. Go to the next. It's a macroaneurysm involving the first main this, and you see a yellowish spot surrounded by red along an arteriole, and this has given rise to resultant features at the macula, but this is classically a macroaneurysm. CRVO, where you see a central kind of hemorrhages, exudates all over, all in the superficial layer. The macula is also involved in this. And then a combined BRAO and BRVO, which you see that there is an occlusion, you can see an umbilus somewhere, and you know that you're dealing with this. The CRAO, which is the emergency, where if you notice it, you can give relief, some relief to the patient if you do a paracentesis within the first 3 hours, and the other methods of pushing the embolus out works in some, doesn't work in some, and this is the CRAO, another picture of the same. So the thing is that when you see these conditions, you know that there is a systemic problem which has to not only be addressed with you, but you need an associated physician to be able to tell you guide you how you have to control this, because it is like, sort of mopping up a wet floor. If you don't stop the flow, you're going to keep on mopping up for your life, and as it is, it takes a very long time to mop up everything. So tell the patient to get his diabetes, blood pressure, cholesterol, whatever it is, in order. Speak to the physician, see that they get the proper line on the road, and for yourself you can do the relevant investigations which are required and start the treatment according to whatever you see. Now if you see this is dot blot hemorrhages, flame shaped hemorrhages, there's a lot of edema in the center, do an OCT, see what is this like, and then you might resort to anti-VEGF treatments or steroid, you can inject steroids, or sometimes when it is localized lesions, you can get away with a laser treatment, and then you have to watch what is the condition going to fare like. So these are all other pictures which tell you the same, the severity, and you know what is the severity. Now this is a plaque like, there's a very dense plaque which is at the macula. You have to prognosticate to the patient that his visual, this however much you do is not really going to be great at the end of it. So these are things that you learn when you sort of see these patients, because you have to talk to the patients and you have to give him a kind of a realistic attitude about what is happening. Again, neovascularization, I'm not going to get into this. Hypertensive retinopathy, a conglomerate of soft exudates, flame-shaped hemorrhages, you know that, and the hypertension history, you know we are dealing with this. If you get some exudates coming to the macula, you know that it's going into the phase of a malignant type of hypertension. These are other senator pictures of hypertensive retinopathy, the malignant hypertension where your disc is also edematous, you might get hemorrhages. the central retinal artery occlusion, which is a cherry red spot, again a red spot on the eye, but you get a surrounding kind of white area, so you know that you're dealing with this. This is the branch arteriola, affects the arteriole, and it's along a segment. The rest of the retina looks okay. Central retinal vein occlusion, superficial hemorrhages overriding the macula. And then the branch vein occlusion, where it's affecting a branch of the vein, and you know that this is how it is. Then coming to your ARMD, you see where the lesion is a grayish kind of a lesion. It might be yellowish and situated in the deeper retinal layers. There are hard exudates surrounding it, and it appears grayish, so you know that there is fluid. Drusen, which is again in the deeper layers, it's like is the first dry kind of ARMD that we are talking about. Or the wet AMD, which is on the right hand side. If you see this lesion, you see different shades. This is in the like preretinal, this is subretinal, and this is in the deeper layer. And this, if you see, is these huge lesions are generally related to the polypoidal choroidal vasculopathies. Preretinal subhyaloid hemorrhage can be traumatic, can be because of other systemic causes. This is a systemic cause because you get a lot of exudation over it. Then we come to the relatively cool things where you get these yellow spots, which could be retinal dystrophies, degenerations, whether it is a Stargardt's and along with certain flecks on the retina, or there is drusen, or there's an adult vitelliform where you get a small kind of yolk-like thing. These are all lesions which appear like this, but you have to see the level and decide what we are talking about, because these don't require any form of acute treatment. And this is fundus flammimaculatus, which often accompanies the Stargardt's disease. Now, a egg yolk appearance characteristic, you know that you're talking about Best vitelliform degeneration in the early stages. Later, it is replaced, and it doesn't look yellow, so it's not under my purview. Something like this appearing red in the peripheral retina, they've already spoken about. Retinal tears, starting with a detachment, you have to treat immediately. Inflammatory conditions, again appearing yet, but in the deeper plane. The FFA helps you to find out what it is, categorize, because if you get a typical kind of fluorescein pattern, you know that you're dealing with this. And so, as well as the other conditions like the APMPP, the mudes, and the toxoplasmosis, where there is scarring, but in the initial phase, you just see it as a yellow blob. And this is old, and some scars are there, but there are some fresh lesions of toxoplasma, punched out lesions are there. Chloroquine maculopathy, history of chloroquine intake, bullseye appearance, which appears something like this. It need not be classically brown, it can sometimes appear like this. CMV retinitis, again, it's a tomato ketchup appearance with blood and soft exudates. And connective tissue disorders, you get some whitish lines or red lines, which could be angioid streaks. So, and then coming to tumors, these tumors are rather large, but you can get smaller areas. That is, it could be a metastatic lesion, it could be a leukemic retinopathy, or it could be a retinoblastoma. Again, this is a huge lesion, you can't miss it, but sometimes there are small things, especially if you see the other eye of the patient, you'll find probably a small lesion in the periphery, which is very important to treat immediately, because otherwise this child will land up with this kind of problem, requires all the kinds of subtenons injections of the chemotherapeutics and radiation, etc. for this patient, and sometimes enucleation of the eye. So these are emergencies, that is the CRAO, BRAO, BRVO, CRVO, AMD, PCV, BRVO, retinal tear. Now the thing is, when I may say emergencies, I mean emergency from the point of view of the patient, because he has suddenly lost his vision. It may not be, it may be a relative emergency for you, but for the patient, it's a true emergency. Then punctures, if injury, traumatic macular holes. And relative injuries where we think relative, again in a macular hole, but the patient will complain of a black scotoma, diabetic macular edema, bleeds anywhere, which is especially involving the macula, CMV retinitis, choroiditis, and posterior scleritis, where it is hazy and you see a yellow region over there. These are all non-emergencies, dystrophies, colobomas, degenerations, myelinated nerves. Myelinated nerves, you have to be sure that, you know, it's in the superficial plane. Don't mistake it for, because many a times people have had a melee of investigations because they thought there was some kind of an osteoma or something at the back. And how do you manage? You identify the cause, relevant investigations, documentations, whether ocular or systemic, and treat and plan. Both the ocular and systemic have to be addressed. So the steps are
Ruby,
the
you'll
same:
need to sum
diagnosis, you
up
do a
now.
detailed eye examination, and then you do your investigations like gonio, B-scan, FFA, color photo, OCT or OCTA. The systemic workup is important because this is very important from the patient's cardiovascular risk factors have to be addressed. And if it's a CRUO, treat it. If it's a lattice, treat it. And treatment is generally runs on to laser photocoagulation, intravitreal injections of anti-VEGFs, steroids, surgery, cryotherapy, and medical line of therapy. Thank you so much.